Good evening, ladies and gentlemen, and congratulations to the IDEC Pune team. And this is Dr. Arvind taking you through the last session, or what we call as the finale for the day. And then this talk is going to be given by Dr. Silvio Inzucchi, who will shortly be introduced to all of you. And he'll be talking about something very interesting: diabetes medication for cardiovascular protection. As you're looking at the screen, I would like to tell the delegates that close to 30,000 people have registered, 29 countries, and this has been a great event that's been going on. Now I request my co-chair, Dr. Archana Sagda, to introduce the speaker, and we move on from there.
Good evening, everyone. Now we come to the last session of the day, and it is a pleasure to introduce Dr. Silvio Inzucchi. He is a professor of medicine at Yale School of Medicine and the clinical chief and clinical director of the Yale's Diabetes Center. Over to you, Dr. Inzucchi, for your talk.
Well, thank you very, very much. It's a great pleasure to be here this evening with you. My topic of the day is glucose-lowering medications and the prevention of cardiovascular disease events. The way I've structured my comments is to first look at glucose lowering and the impact on cardiovascular risk reduction. Then we'll discuss the landscape of type 2 diabetes medications. And we'll transition to the SGLT2 inhibitors, their impact on cardiovascular outcomes, the GLP-1 receptor agonists and their impact on cardiovascular outcomes, and then take a trip to the past, maybe into the future, with a new look at the thiazolidinediones, or the TZDs. And finally, we'll describe the updated treatment guidelines. In this slide, we have a summary of the impact of tight glucose control on both microvascular as well as macrovascular complications. And we can see that whether we're discussing type 1 diabetes or type 2 diabetes, the impact on nephropathy, neuropathy, and specifically retinopathy is unquestioned. The tighter the glucose control, the better are the results of these complications. However, what's been very frustrating to the field has been that the impact of tight glucose control on cardiovascular disease outcomes, and specifically cardiovascular mortality, has been essentially neutral. In fact, in one study, the ACCORD study that was published in the early 2000s, we can see that mortality was actually increased in those patients that were randomized to the more intensive arm. And this gave pause to many of us in clinical trials in diabetes as to what may be the specific impact of glycemic control on cardiovascular disease. A bit of a conundrum, because obviously cardiovascular disease is the main cause of mortality in this condition. What about the landscape of therapies now available for us to use in our patients with type 2 diabetes? Well, this is based on the pathogenesis of this disease. And we know a lot more about the pathogenesis of type 2 diabetes over the past 10 years than we ever have before. We know that most of the initial abnormalities occur in peripheral tissues, such as skeletal muscle and the adipocytes. And here these organs demonstrate decreased peripheral glucose uptake, meaning insulin resistance. In compensation to that, pancreatic insulin secretion is increased initially, but in some individuals predisposed to type 2 diabetes, that hyperinsulinemia cannot be sustained. And therefore, there is a secondary pancreatic defect that occurs in patients with type 2 diabetes. Pancreatic glucagon secretion may also be paradoxically increased. The liver plays a role. Hepatic glucose overproduction contributes to hyperglycemia, and that's another manifestation of insulin resistance. The incretin system is also at play. Incretin hormones are generated from the intestines and travel to the endocrine pancreas to stimulate insulin secretion, suppress glucagon secretion, and that signaling is deranged in patients with type 2 diabetes. And finally, the kidney probably plays an important role as well. In normal individuals, the glucose excretion threshold is 180 milligrams per deciliter, but in patients with type 2 diabetes, that is increased to at least 230, if not 240 milligrams per deciliter. So we can say that the kidney compounds the hyperglycemia in patients with type 2 diabetes. We now have 12 individual drug classes to manage patients with type 2 diabetes. These are the 7 that are most widespread use. 2 drugs that address the insulin deficiency, 2 drugs, metformin and TZDs, that address insulin resistance, 2 drugs that address the incretin defect, and the SGLT2 inhibitors, which stand alone as glucosuric agents to address the hyperglycemia that is aggravated by increased glucose absorption at the level of the nephron. These are now the 7 major drug classes, each with a variety of members, each with a specific hemoglobin A1C lowering potency, and each with specific mechanisms of action, and of course, positives and negatives, and a specific cost, although obviously the cost is somewhat dependent on the healthcare system that you're working in. I wanted to focus today on metformin, TZDs, GLP-1 agonists, and SGLT2 inhibitors, because these are the 3 drugs with either solid or some evidence of cardiovascular benefit. We don't have time to talk about metformin or extensively the thiazolidinediones in terms of their early data. Suffice to say that metformin may reduce cardiovascular events, specifically non-fatal myocardial infarction, but these studies are very small and mostly conducted in the pre-statin era. And therefore, one can say that while metformin may have a cardiovascular benefit, the data in support of that contention is not entirely robust. The TZDs are extremely controversial. I placed a plus minus here because some of the evidence from the past suggests that pioglitazone, one of the thiazolidinediones, may reduce atherosclerotic events. However, both TZDs increase edema, weight gain, and may increase the risk of heart failure. So there is certainly a plus minus that you get with the TZDs. And we're going to be spending most of our time this evening addressing the 2 newer drug classes which clearly have cardiovascular benefits, the GLP-1 receptor agonists and the SGLT2 inhibitors. And not to forget that each of these drug classes, whether we're talking about insulin, sulfonylureas, metformin, TZDs, DPP-4 inhibitors, or GLP-1 receptor agonists, including the SGLT2 inhibitors, we need to understand that each of them have negative potential adverse effects, and that must be balanced along with the positive aspects to use of these medications. This is the old ADA-EASD guidelines for the management of hyperglycemia in patients with type 2 diabetes. Importantly, this was before the large-scale cardiovascular outcome trials began to generate exciting data regarding the SGLT2 inhibitors and the GLP-1 receptor agonists. So initially, the group felt that healthy eating, weight control, increased physical activity, and diabetes education formed the foundation of type 2 diabetes management. Metformin was considered the first drug to use as monotherapy, so long as it could be tolerated. And if the hemoglobin A1C target was not achieved, then other therapies would be added so that dual therapy with metformin, such as with a sulfonylurea, a TZD, etc., could then be used to increase the likelihood that patients would achieve their glycemic targets. If the patient still was away from their A1C target, then a triple therapy regimen could be considered, for instance, metformin, a DPP-4 inhibitor, and then one of these 4 agents. Combination injectable therapy would be reserved for those patients who were not achieving their glycemic targets despite triple therapy. In 2008, in the United States and also in the EU, regulatory agency insisted on large-scale clinical trials that demonstrated cardiovascular safety of newer medications brought to market for type 2 diabetes. The first series of these studies were involving the DPP-4 inhibitors, and we don't have time to get into the details of these studies. Suffice to say that each of them were essentially neutral for the primary outcome, which was MACE, major adverse cardiovascular events. So this meant that these drugs could be used safely in patients with cardiovascular disease because most of these studies included patients who had already had cardiovascular events, but they did not provide necessarily any benefit to those patients in terms of reducing MACE. The next series of trials that I want to describe are from the SGLT2 inhibitors. Just in review, the SGLT2 inhibitors increase glucose excretion through the urine. SGLT2 is a cotransporter that is expressed in the proximal nephron and is responsible for 90% of the glucose reabsorption from that site. 10% is through SGLT1, although SGLT1 is mainly expressed in the intestines. As long as the glomerular filtrate glucose concentration is kept under 180 milligrams per deciliter, there is no glucose excretion. However, now if we pharmacologically block SGLT2, we can induce glucosuria to the tune of 70 to 80 grams per day, which translates to about 300 kilocalories per day. The first SGLT2 CV outcome trial to report was with empagliflozin, and this is the EMPA-REG outcome trial. And this was the most dramatic result from this trial, a 38% reduction in cardiovascular mortality, something that had never been reported previously with any glucose-lowering agent. One important observation is the early divergence of the event curves, such that by 2 months you already saw a statistically significant difference in terms of cardiovascular death in those patients that were randomized to empagliflozin. So the EMPA-REG outcome trial was the first of the SGLT2 inhibitor CV outcome trials, and this demonstrated a modest reduction in 3-point MACE, mainly driven by this impressive effect on cardiovascular death and translating to an all-cause mortality advantage as well. In addition, heart failure hospitalization, what's often nicknamed HHF, was reduced 35%, and there was also a 39% reduction in the progression of chronic kidney disease. Subsequently, the CANVAS study, the DECLARE study, and the CREDENCE trial demonstrated substantial benefits, perhaps not identical to empagliflozin, but similar from canagliflozin and dapagliflozin. The most consistent benefits from this drug class appears to be with reduction in heart failure hospitalization, and you can see from DAPA to CANA to EMPA, there is a 27 to upwards of 39% risk reduction in this important cardiovascular outcome. This is a meta-analysis that was published earlier this year, looking at the 4 major cardiovascular outcome trials in this field. And you can see that for MACE, the mean reduction is 12%, with a stronger effect in those patients undergoing secondary prevention. In other words, those that have had cardiovascular events. Importantly, an average reduction in heart failure hospitalization of 32% was demonstrated, and no significant heterogeneity, whether somebody had or did not have prevalent cardiovascular disease. Similarly, this is now the data cut by the presence of heart failure at baseline, and you can see that irrespective of the presence or absence of heart failure at baseline, patients had a significant and consistent reduction in heart failure hospitalization. This exciting data led to dedicated heart failure studies, and this is the first to report DAPA-HF, which used dapagliflozin in a group of patients of more than 4,000 having HFrEF, heart failure with reduced ejection fraction. Importantly, you didn't have to have diabetes to enroll in DAPA-HF. In fact, 55% of the patients in DAPA-HF did not have diabetes. There was a 26% reduction in the primary outcome, which was worsening heart failure or cardiovascular death. And one of the main questions we had is whether patients with type 2 diabetes were the sole subgroup to benefit from the SGLT2 inhibition. And the answer was no. Both patients with and without type 2 diabetes had a very, very similar benefit. So clearly, the drug class is working not through glucose, at least for this specific cardiovascular outcome, and that's been demonstrated in other trials as well, that the reduction in hemoglobin A1C and fasting glucose has nothing to do with the cardiovascular benefit of this class of medications. Other heart failure studies are currently underway. There is DELIVER with dapagliflozin in HF patients, that would be those with preserved ejection fraction, and 2 studies using empagliflozin, emperor-reduced and emperor-preserved. And you can tell by the titles as to which subgroup of heart failure patients those trials are targeted at. We should have data over the next 1 to 2 years to hopefully confirm the cardiovascular benefit in heart failure patients from the SGLT2 inhibitors. And there's always controversy as to whether HFpEF will behave similar to HFrEF, but it'll be very exciting during this time to look at those data as the trials are resulted. Let's talk now about the GLP-1 receptor agonists and their cardiovascular outcomes. The GI tract sends signals to the endocrine pancreas, both neural and neutral, but also hormonal signals, and these are the incretin hormones, glucagon-like peptide number 1 and glucose-dependent insulinotropic peptide, or GIP. The hormone signals then regulate both beta and alpha cell secretion, and they tend to increase insulin secretion in the postprandial setting and decrease glucagon production. Importantly, the DPP4 enzyme metabolizes endogenous incretin hormones, and therefore DPP4 inhibitors will increase the endogenous level of these incretin hormones as it impairs the action of that important enzyme. We talked about the positive trials from the SGLT2 inhibitors. There was one that was pending in terms of its results, but we just heard this week that the VERTIS-CV trial using the 4th SGLT2 inhibitor, ertugriflozin, was actually neutral for major adverse cardiovascular events, although one of the secondary outcomes for heart failure hospitalization was apparently positive. So this result will be presented, and my understanding is next month at the American Diabetes Association meeting. It will be very interesting to see exactly what the specific results were for MACE and the specific components of MACE. But let's get back to the GLP-1 receptor agonist. The initial trial looking at this drug class, ELIXA, in a group of patients with acute coronary syndrome was neutral. And let's look now at the more or less positive trials from this specific drug category. Here is now LEADER with liraglutide, SUSTAIN 6 with semaglutide, exenatide's XL studies, and dulaglutide's REWIND study. And you can see that some of the results are not as perhaps consistent as we've seen with the SGLT2 inhibitors, but most of the studies have demonstrated a reduction in 3-point MACE. Again, that's major adverse cardiovascular events. And one of the trials has shown a demonstration of a reduction in cardiovascular death. That would be liraglutide in LEADER. Exenatide was almost positive for MACE, but just missed. This medication was tested in the EXCEL study and is one of the several GLP-1 receptor agonist trials which were essentially neutral, but there may have been some methodological limitations of the specific study. And the REWIND study using dulaglutide is notable because it had mainly a primary prevention population, and therefore it is conceivable that the GLP-1 receptor agonists are not only effective in reducing secondary cardiovascular events, but may also prevent patients without prior cardiovascular disease to have improved cardiovascular outcomes. This is the most recent meta-analysis from GLP-1 receptor agonists, and we can see that when you pool all the data together from 7 trials, you get an average 12% reduction in MACE and, in fact, a 12% reduction in cardiovascular death. But only one of these trials, specifically LEADER, has had robust data in terms of specific effect on cardiovascular mortality within its trial. So this is what all of the cardiovascular outcome trials look like now. Neutrality with the DPP4s, positivity with the SGLT2 inhibitors, with the exception perhaps of VERTIS-CV, but we'll have to wait for those data to know for sure, and then some variability with the GLP-1 receptor agonists. Briefly now, I wanted to highlight a more recent study using the thiazolidine pioglitazone. This was our IRIS study, the insulin resistance intervention after stroke. We randomized almost 4,000 patients to either pioglitazone or placebo. Each of these individuals had had an ischemic stroke or a TIA, were not diabetic, but had insulin resistance based on the HOMA equation greater than 3.0 and no heart failure. They were followed for 5 years, and essentially the primary endpoint was MACE. We called it fatal non-fatal MI and fatal non-fatal stroke. If you recruit patients with insulin resistance and you exclude patients with diabetes, you end up with a pool of patients who have pre-diabetes. Based on the hemoglobin A1C, about 2/3 of our patients could be categorized as having pre-diabetes. And this is our primary outcome, fatal non-fatal MI and stroke, reduced by 24%. These data have now led to updated treatment guidelines. Remember the original guidelines from 2015. The update from 2012 was the inclusion of the SGLT2 inhibitors and the addition of combination injectable therapy involving basal insulin plus a GLP-1 receptor agonist. But importantly, these recommendations were not based on a solid evidence base for long-term clinical outcomes. The clinician was encouraged to match the patient to the specific drug based on pathophysiology, based on tolerance for side effects, based on hemoglobin A1C potency. But there was nothing in 2015 until EMPA-REG outcome to demonstrate that one drug class was better than another in terms of important cardiovascular events and certainly renal outcomes as well. Fast forward to 2019, these are now the updated consensus report recommendations from the ADA and the EASD. We don't have time to get into all of the guidelines, but just focus on the left-hand side of this figure, and specifically the first step after metformin monotherapy has not achieved glycemic control is to use a second drug based on the presence of atherosclerotic cardiovascular disease, heart failure, or CKD. So if these conditions are present, specifically ASCVD, we are encouraged to use either a GLP-1 receptor agonist or an SGLT2 inhibitor because, after all, those drug categories have had significant benefits in that population of patients. In patients with heart failure or who have CKD, the data is much stronger with the SGLT2 inhibitors, and that would be the best second-line agent. Importantly, over the past year, the American Diabetes Association, the European Association for the Study of Diabetes, now ask us to consider the use of these drugs, i.e. the GLP-1 agonists or the SGLT2 inhibitors, irrespective of baseline A1C or the individualized hemoglobin A1C target, meaning that if a patient has well-controlled diabetes on metformin, based on the presence of these underlying complications, we are encouraged to add these medications to the anti-hyperglycemic profile, even if the hemoglobin A1C is at target. That's a radical change for diabetes organizations. It may not be as radical for cardiology organizations. These are the 2019 ESC guidelines for the management of diabetes as well as pre-diabetes. And what I wanted to focus on are the major recommendations for those patients with cardiovascular disease. In drug-naive patients, you're not supposed to begin, at least according to the ESC, you're not supposed to begin with metformin monotherapy. You should go with an evidence-based strategy of an SGLT2 inhibitor or a GLP-1 receptor agonist. Moreover, if you're already on metformin, irrespective of hemoglobin A1C, simply based on the underlying characteristics of that patient with ASCVD, we are asked to add an SGLT2 or a GLP-1 receptor agonist. These guidelines go a little bit beyond what ADA and EASD say, because those two latter organizations still feel that metformin is the best underlying foundational therapy for patients with type 2 diabetes. The other important difference is the designation of high risk or very high risk individuals by the ESC, which, as you can see here, encompasses the vast majority of patients who have type 2 diabetes. So allow me to summarize. Correcting the major metabolic abnormality of type 2 diabetes, which is hyperglycemia, has had little effect on its major complication, cardiovascular disease. As regards the older glucose-lowering agents, insulin and SUs don't reduce cardiovascular events. Metformin might, but the database in support of this notion is not robust. Given these and other controversies, in 2008, in the United States, the Food and Drug Administration mandated large outcome trials to confirm the cardiovascular safety of new glucose-lowering drugs. And this guidance to industry led to essentially a cottage industry of large CV outcome trials, most of which were also powered for efficacy and therefore could tell us not only about safety of these medications, but whether they could actually reduce cardiovascular events. The first of these CVOTs, the first series, were with the DPP-4 inhibitors, and they actually proved neutral. So they were safe in patients with cardiovascular disease, but not effective in reducing cardiovascular complications. 3 SGLT2 inhibitors, EMPA, CANA, and dapagliflozin, reduce MACE and/or heart failure hospitalizations in patients with type 2 diabetes and established CVD. These drugs also appear to reduce hospitalizations for heart failure and the progression of CKD in those at high cardiovascular and renal risk. 4 GLP-1 receptor agonists, liraglutide, semaglutide, albiglutide, which is no longer widely available, and dulaglutide, also decrease MACE in patients with type 2 diabetes who have established CVD or are at high cardiovascular risk. And finally, the TZD pioglitazone reduces fatal, non-fatal MI and stroke in insulin-resistant stroke patients, many of whom have had prediabetes. These positive trials, specifically those involving the SGLT2s and the GLP-1s, just over the past 4 to 5 years, are leading to a rapid evolution in our approach to managing type 2 diabetes and should be enormous interest to both primary care physicians, obviously endocrinologists, but also cardiologists. With that, I will conclude, and I thank you so much for your attention.
Thank you so very much, Dr. Silvio. I think we have time for a few questions. I think my question actually comes from your last few slides. Somebody has asked a question that ESC and EASD, when they combined, they said that you can use an SGLT2 as a monotherapy, but when EASD moved in along with ADA, they say that metformin should be the first line and then it should be an add-on, and I'm a little confused. Why EASD has 2 different phases?
I'm also confused. I don't know why that was. I think they signed on to the ESC guidelines, but I'm not sure they had as direct input as into the ADA guidelines. The ADA EASC guidelines, and I was involved in the 2012-2015, that's a joint statement. In other words, there are 5 members from each organization that meet several times, either live or by video conferencing. So it is a guideline that is created de novo from those organizations, and each organization has to have 100% approval with those recommendations. My understanding is that the ESC also asks for what's known as endorsement or a stamp of approval from other organizations, including the EASD. But I think that the genesis of those recommendations were mainly cardiologic.
What is your personal view? Should metformin be the first line and then SGLT2 as an add-on? What do you say personally?
Personally, I still endorse metformin as the best underlying treatment, but it's a bit of semantics if you think about it, right? Because if ADA ESD now say that you begin with metformin and then you add the second drug, but no longer is the addition of that second drug contingent on the hemoglobin A1C, all patients will essentially be on either a GLP-1 or an SGLT2 inhibitor. The main difference in those 2 statements or those 2 approaches is whether they take metformin. And I think most of us would agree that metformin is at least harmless, right? It doesn't cause any toxicities as long as patients can tolerate the drug in terms of the GI tract. So whether you have a patient who is on an SGLT2 or a GLP-1 with or without metformin, I think that those patients will benefit significantly, and maybe the metformin as underlying foundation will reduce glucose even further and have a protective effect on microvascular, maybe even macrovascular disease. So I think it's a bit of semantics, an important difference, because it changes how, particularly in primary care, how we sequentially approach our patients. But if you think about it, I think the key issue is whether they get on one of these evidence-based strategies, not whether they're on or not on metformin. But in my practice, because metformin is so widely used, it's so inexpensive, so safe, I use it in the vast majority of my patients with good, good enough kidney function that can tolerate it.
Yeah, and several people have asked a similar question, but before I ask the question, several people have also said that they have liked your tie and then it looked very nice on the webinar. So having said that, this is a question.
It's a Gustav Klimt.
Yes. So the question goes like this, that Doc, we are extremely happy about how you presented the entire thing. We do understand that there is a good evidence with GLP-1 and CVOTs and the benefits of GLP-1. But when it comes to GLP-1, SGLT2 seems to be doing everything a little more than what GLP-1 can do at a much lower cost. Do we really need a GLP-1 in today's basket of drugs?
Great question. I tend to agree, but I think that the issue that I struggle with is that as the data emerges from the SGLT2 inhibitor field, and we'll have to see what Virtus CV teaches us, right? And that's going to be about a month away. But I think the story that's developing is that if we can think about the way these drugs work, it does not seem to me that the SGLT2 inhibitors are necessarily anti-atherosclerotic. In other words, their effect on myocardial infarction is very small. The effect on stroke is negligible. So it doesn't seem like these medications work on atherosclerosis itself. You saw the event curves, right? It's impossible for there to be a decrease in cardiovascular mortality at 2 months if this is driven by atherosclerosis. That should take 12 to 18 months, as we see in lipid and blood pressure trials. When you look at the GLP-1 receptor agonist, there's more consistency in terms of the components of MACE. Cardiovascular mortality goes in the right direction, stroke goes in the right direction. With semaglutide, stroke goes hugely in the right direction, and so does myocardial infarction. So, and the event curves begin to diverge in the classical CVD style of about 12 to 18 months. So it seems that the GLP-1s are more anti-atherosclerotic, whereas the SGLT2's effect is mainly on heart failure, maybe hemodynamics, maybe reducing cardiovascular mortality through those effects as opposed to athero. So I'm tempted to use both if costs were not an issue, because I'd say we prevent death and heart failure with the SGLT2, we prevent athero with the GLP-1. Maybe even the TZDs, as we showed you, the event curves there seem to be more of an atherosclerosis, but there are issues in terms of heart failure in some of the older studies. So I'm tempted to say that they both work differently, and I want to use them together, but I don't like to use them together because they're so expensive in combination. But I agree with you. I think that sometimes we get too obsessed with pathophysiology as academic endocrinologists. At the end of the day, they both help patients, and I agree that the SGLT2s are less expensive. They're oral tablets. They require no training of the patients, and they're more accepting of patients. So I tend to favor SGLT2s, but clearly there's a role for GLP-1 agonists in the more obese patients because there tends to be more weight loss with those medications.
Dr. Archana, you have any questions?
Yes, we have a couple of questions here. One is regarding DAPA. The question is that do you see DAPA as the next heart failure drug, considering the DAPA HF results? And as a continuation to that, do you foresee a RCT comparing it to the heart failure drugs in non-diabetics? Or are there any such ongoing studies going on?
So yes, I mean, dapagliflozin, actually in the United States, the manufacturer of dapagliflozin was just awarded the labeled indication from the FDA for heart failure, irrespective of the presence or absence of diabetes. So that's extraordinary, right? Here, I tease my cardiology friends that they have stolen our drug. This was a drug that was developed with and by and for endocrinologists, and now the cardiologists are will be prescribing this medication. I'm kidding, obviously, but it's an interesting evolution of who is prescribing these medications. It's very interesting. We did a quick analysis in our health system here in Connecticut in conjunction with colleagues at the St. Luke's system in Kansas City, Missouri. So we pooled our electronic medical records and we asked a very simple question. Who sees these patients? Who sees patients with type 2 diabetes and cardiovascular disease? Who sees patients with diabetes and heart failure? And the answer is not the endocrinologist, it's the cardiologist. 4 to 1, 4 times as many patient contacts in these two health systems from cardiologists to endocrinologists. In heart failure, it's 8 to 1. So think about that. It is much more likely that a cardiologist will touch a patient with cardiovascular disease and diabetes, heart failure and diabetes, than will an endocrinologist. So if we're going to impart the benefit from these drugs in a cardiovascular population, it really has to be done by the also the primary care physicians, but our study was mainly comparing those two specialties. So the answer is yes, DAPA appears to be a heart failure medication. Has nothing to do with glucose. It pains me to say that as an endocrinologist. I don't doubt that the other SGLT2 inhibitors will have a similar effect. We'll have to see what the Emperor series show us. We'll also have to digest the HFpEF studies because now I'm not a cardiologist. I know very little about heart failure, but my colleagues tell me that HFpEF is a difficult disease both to diagnose and also to treat, and that many of the therapies that have been successful in HFrEF have failed in HFpEF. Some have come very close to working, but it's almost a bone of contention amongst cardiology specialists that HFpEF doesn't have any good treatments. Will SGLT2 inhibitors become the first dedicated HFpEF treatment? We'll have to wait for Emperor Preserved and also for Deliver, which is the dapagliflozin study. So those are the trials that I'm looking forward to.
Thank you so much. Dr. Arvind, any questions?
I have a very interesting question again, which has come from somebody from Sri Lanka who's been watching this. It's a very interesting question, Dr. Silvio. He has asked you a question. You see a patient in your outpatient clinic with a mild pedal edema, almost no symptoms of heart failure, but then you do a pro-BNP which is higher, and the patient is on CANA. Would you like to shift this patient to DAPA based on evidence that which works better with heart failure?
Well, I think I'm very conservative, and I never like to change. Ask my wife. I don't like anything to change. So I think that if somebody's doing well on a medication, why change? And there won't be a canagliflozin heart failure study, but there was a reduction in heart failure hospitalization in both CANVAS as well in CREDENCE, which was a high-risk renal population. Yeah. So in my heart of hearts, I suspect that the drugs work similarly. And you see even ertugriflozin, which did not hit MACE or, well, we don't know specifically about cardiovascular mortality, but the press release, which is all we have, the top-line data, does not suggest that it is as good a result as we saw with EMPA-REG or even CANVAS and maybe even DECLARE. But there was that heart failure benefit, although we don't know what the size of that benefit is. So it seems that the drugs work similarly, whether it's CANA, DAPA, EMPA, maybe even ERTU, on heart failure. So I suspect that person's edema, if they suspect they may have a little bit of heart failure, I suspect CANA is working. Now, as you know, there's this little stain on canagliflozin, which was the amputations and the fractures that were seen in CANVAS. Was that bad luck? Because it's not been seen in CREDENCE, which you would think would be a higher risk for both amputations as well as fractures. and has not been seen with DAPA or empagliflozin. So there's always a little concern I have with canagliflozin, particularly in higher risk patients. But I think that you could easily just keep them on canagliflozin. I think you could switch them to one of the other SGLT2 inhibitors, but I think that person is very high risk with a high NT-proBNP, a very potent risk marker for the future development of heart failure. This is actually where endocrinologists and primary care doctors can be very important, not in heart failure treatment, because in most societies, cardiologists are involved in managing those patients. We can help educate the cardiologist so that we can collaboratively work on those patients. But the patients that have not yet seen the cardiologist, these are the patients in our practices, both primary care as well as endocrinology, that will develop heart failure in the future. It's a very common scenario in obese type 2 diabetic patients with hypertension. If you add the high NT-proBNP on top of that, they're at extraordinary risk for the future development of heart failure. And as we know from the data that I've shown you, we can actually impact that. We can decrease their risk of developing heart failure in the future.
Thank you very much, Silvio. I think, Archana, if there are no more questions, I think we can wind up the session. Thank you so very much.
They will be put on the website. There are many more questions, but they will be taken on the website. Thank you so much.
Okay.
Yeah, Archana, before we sign off, I just have one announcement to all the delegates. Yes, we know that there was a lot of problems for people to actually log in today because there was crowding of the websites. And more than 30,000 people tried to log in almost at the same time from across the world. And our IT team is doing its best to see that it gets sorted out. By tomorrow, nobody should have a problem. And I've spoken to the organizing secretary, Dr. Sanjay, who is also there on the right now, that he will also have some announcements and alternative websites. So I'm sure tomorrow will be a very fruitful day.
Thank you very much, Dr. Arvind. Thank you, Dr. Silvio. It was a wonderful lecture. We enjoyed listening to it. And Dr. Archana, thank you very much.